when we talk about the key challenges, which I think all organisations have, it won't be anything new to you, I think, to talk about the ones that we fairly well know are evident, and that is, all of you have witnessed the increased demands that are occurring now against the availability of resources, the ageing population, the technology, the increase in pharmaceutical products that may be useful. You all know that. I'm not going to go into great detail about that. I think there is a glimmer of hope on the horizon, because the change in demography is only going to be relevant if people are getting older and iller, or they're not getting any better, or they're getting more disabled. If they're not as disabled, if they are healthier than they were 20 years ago, then certainly we can see both in Counties Manukau and in Great Britain that the demographic time bomb, as they called it, may not be as bad as we think, and early signs are that it may not be so. Certainly that's from data that we've gathered in the UK. And then the other thing that I find is quite evident here and elsewhere is the high expectations that the public have, that politicians have, and many healthcare professionals have. And that's something I think is very difficult to meet without changing the way in which the public appreciate, value and expect of their healthcare service. So there's an element there. And when I talk about healthcare professionals, and when I'll be talking about, and I may use the word clinical leadership, let me make this quite clear. My idea of healthcare professional and clinical leadership is not confined to people who've got a medical degree or a nursing degree or a physiotherapy degree. I believe that clinical is anyone who's actually involved in the passage of the patient through the hospital. And if you extend it even further, you can talk about people in public health and community health, where they are clinical workers as well, in that they're looking at the way people pass through the system, people who are ill, disadvantaged or disabled. And I think that's very important, because when people talk about clinical leadership, automatically think we're talking only about doctors and nurses. We're not. We're talking about everyone that's got and I'm sure everyone in this room, its clinical leadership is relevant to them. The other thing that strikes me here, but everywhere else I've been as well, that there are certain elements within the organisation, and I've got to say it, which are rather reluctant and lack any urgency to actually move forward and tackle the issues that they hopefully still hold to be valuable and true, and take it forward. What I've discovered is that probably Counties Manukau is one of the few places that I've been to in the world where you're getting via co-Awatea, and before that time, you've got all the tools ready for you to move forward. The ones for leadership, for example, the ones for engaging populations, the ones for improving chronic disease management, all these things which others haven't put together, you've got. And you've had them for some time. So why isn't it that there's not faster progress being made? Simply, I think, and you can criticise me and I'm prepared to take brickbats off you, it's because we all know what should be done. We all think we are doing something about it. We all know we've got the tools to do it, but we're not engaging. We're not getting things done. And I know you may look at yourself and say, well, he doesn't know what I'm doing. I'm doing a lot in that area. Yeah, I know there are examples of excellence that I've come across, excellence in the world, not just in New Zealand. But the feeling I've got is that people know what to do and they're not doing it. Why aren't they engaging? And as I say, please accept this. It's not just your criticism of all of us. It's a criticism of the whole of the healthcare service. I see it in the world. Particularly in Wales, we've got the same problem. In England, well, in England, they don't know what the hell they're doing. Oh, I'm being recorded. But actually, that is the big challenge. The big challenge here is getting people on board, getting people to realise they can do it. And why? Because of the fear of change. And the fear of change is one of fear of change itself, fear of change, my job's going to be involved, I may lose my job stability or whatever. political change. You've got a government in place now who've got a particular ideal. Could be, I don't know, in a few months' time that government may go and you'll have another one. And you've got a fear of that. Is it worth doing what we're doing when there's going to be a change in government every 3 years in New Zealand? We've got at least 5 years to wait for a new government. Demographic change, the fear of that. And the fear itself of actually doing something that's different, I think, of failure. The fear of failure itself. That, I think, is a very important issue. When I talk one-to-one to people, they say, yeah, but what if? You know, if everybody keeps on saying what if, you'll never get anything done. So I'm coming I'm not going to go into the other key challenges there are, because I think I've gone into the ones that are most important to me. And the theme of the paper I'll be writing for the board will be around that. And I'll be talking to you about it if you're prepared to come back again in a week or so. But what are the important things that one needs to have in place in order to get people moving, in order to get people on board? And I think, and I'm sorry if I'm using words that are old-fashioned and ill-used, but you know, an overarching, compelling vision for a well-integrated system. The thing is, you do have that. This is what strikes me. You go around, and I go to places in other parts of the world, and I talk to them. They don't know what I'm talking about. They don't know what the vision is. They don't see. I don't like using mission statements and all this stuff. That sounds antiquated, but they've never thought of it. But you've got one. Workforce and financial strategy that is substantially driving forward the vision. I can't say I've come across that yet. It's there. I can't see everything, you know, I wouldn't expect to. But if you haven't got that, you know, that they link together, workforce and financial vision in driving the vision forward, it's not going to happen. A cogent and coherent direction of travel. You've got that, very largely got that. There are bits and pieces that you need to look at in more detail, I think. But an overriding emphasis on quality improvement and patient safety. You've certainly got that in this place here. In fact, if I had to go anywhere else in the world, I'd find great difficulty in looking at the way in which patient safety, risk management, and the effects of the influence that the organisation must have on quality is paramount here. And I was speaking to the nurse director this morning, and you know, it's quite clear that that's coming through from the nursing point and everywhere else. It's all involved. The other couple of things I just wanted to mention was strong set of values and the centrality of the patient. Now, we all say that we're putting the patient at the centre of our whatever, but do we really do that? Do we? I don't. You know, I'm read to me after a few hours after on a Monday morning when I'm up and I'm ready to do that, I forget about the patient, and we all do. It's nothing to be ashamed of. We don't remind ourselves that the patient is important. We don't remind ourselves of our values. I was at the Tikanga, I see Eric is here, the Tikanga training and the Marae last few weeks, and one thing it taught me was that, you know, there's a lot of values there among Maori, which are shared by certainly people in Wales, and I know are shared by people in New Zealand who are not Maori. And they can be used in a splendid way to always look back and say, but are what we're doing in line with our values, I mean with our vision? I'm not, all I think is that in healthcare systems everywhere in the world the status quo is unsustainable, so we can't just keep doing business as usual. It's just not going to work. And then last of all, and this one is something that it's more difficult to articulate in a New Zealand situation than it is at home in Wales, and that is, I think that there's a moral and economic case to reduce social inequalities and health inequities. Now, I know that's part of your programme, I know it is, but it's not got the emphasis, I feel, through no fault of your own or your executive's own, it's not got that focus that it has, because no matter how good our healthcare service is, if we don't adjust and address those issues, then we'll always have a healthcare service that will never catch up, because there'll always be ill health and there'll be worsening ill health. So tackling that, I think, is very important. I've spoken too long. Any comments on what I've just said, I would welcome. I'd like Pam, where's Pam? Would you like just say a couple of words about what you've been involved in or anything? Would you? Yes?
Sure.
And then if we could open up the discussion then, asking me questions, and then I'm going to ask you questions if I may. Is that all right? I didn't put you on the spot, did I?
Yes.
Yes, okay.
That's all right. Okay, well, I'm Pam, and working with, here, I'll do that. Thank you. Working with Mansel to really progress a couple of things and around these key issues. And one of the things that I'm hoping to do, because I'm actually going to be here a bit longer than Mansel, because we were just a little bit late in catching up. And so I'll be here until the end of June. And what I really would like to do is to continue this dialogue with you guys, perhaps one-on-one, perhaps in just brown bag sessions. But I think we're not going to get all of the input that we really need just today. These are huge questions. We've got several specific tasks that Jonathan has asked us to follow through on. And so I guess my plea to you is, if I call you up and say, hey, do you have a few minutes to have a chat with me about some of this, that perhaps, I know you're really, really busy, but that perhaps the answer would be yes, and I'll come to you, or we can do however you want to do it. But we've just got to get a really good feel for what the ideas are that are out there, and then to actually turn that into the formal paper that Mansel was talking about, because it really is about change. It's about sort of transformational change. And when you first start thinking about it, it doesn't make lots of sense. It's not concrete. I think we will get more and more concrete as we go along. So one of the concrete things that we want to do today with you is we've got a list of 7 questions, and Mansel, I think, will lead the dialogue on that. I'm going to try to keep up with some of the ideas, the general ideas that come out. And then what Mansel and I will do is tomorrow we will put these ideas together, and then by Monday or Tuesday a paper will actually be coming out, and then Mansel will be doing a presentation to the board on Wednesday. So with that, can I turn it back over to you?
Yeah, that paper is taking about, say, 8 weeks to put together, and you will ultimately see it, obviously, and you'll realise that the areas I've spoken of will be dealt with in greater depth, and the reasons why those areas have come out in context. The other thing is, 3 months just being a visiting chair isn't enough. And I feel that you can start things off, you can get some real good progress, but you've got to continue. And I know that I'll be doing that. I'll be continuing to be working with you here until, as long as you want, until the time they say we'll be fine enough and maybe kick him out, you know, and I'll disappear. I won't be here, I'll be hopefully in Wales, but I'm quite prepared to come back as well. So that's that. The other thing is, before I go on to these questions, there may be something that you want to comment on or say, well, we don't agree with you there, or yes, it is. You may think this, but it's actually like that. Are there anything that you want to talk about first before I ask you questions?
May I just ask, while people are thinking, could you list those key, just because maybe my brain didn't believe it, just list those key challenges?
No, the key challenges. Can you read those? Increased demands.
Yep, got it.
Lack of edge. And what do you need? Okay. Yeah.
It will help people think through their questions.
Anything you want to? Yes, sir.
Just one thing that when you look up transformational change, it brings to mind the fact that all medicine is politics, really, and that if we're going to have transformational change, it has to be in primary care rather than secondary care. And if it's going to be in primary care, then it has to be in pre-primary care. And the politics of it, I think, is how do we sheep home responsibility for the individual for their own health?
Absolutely, absolutely, and you know that's the culture story. You know, when you talk about changing culture, people say, "Oh, everybody says that," but they put it in the too difficult to do box. And what do you mean by culture? And it's all about beliefs, attitudes, and behaviours, not just of the people in healthcare, but more particularly of the public and the public's perceptions of the NHS. And we have learned a bit. I'm not just speaking without any evidence base, because in the last couple of years, Jonathan mentioned there was this commission called the Bevan Commission, after an Iron Bevan, who was considered to be the architect of the NHS in Great Britain. And of course, he was from a valley about 2 miles from me. He was Welsh, and what do you expect? So the Bevan Commission was put together to look at reforms of the NHS and to say, after these reforms have taken place in Wales particularly, will the NHS still be recognisable to that person who formulated it? You know, universal, comprehensive, free at the point of free at the point of. That's it. Yeah. Those we want to be preserved. There are many others, but I'm not going into that today. That will be dealt with in a separate paper. But the Bevan Commission was put together by the Welsh Government in a very, very risky way, because they were very brave. They said, we want an independent commentator made up of people with gravitas, people with an international reputation, people whose opinions counted, people who are independent and impartial and not just drawn from Wales. We wanted them to get together to look at what we're doing and say, you're okay, boys, or no, this is going the wrong way, this isn't in keeping with this, that and the other. Now, that could have been a disaster for the Welsh Government. It wasn't. The first Bevan Commission, it's been reconstituted, was very constructive and actually helped the way in which Wales is moving forward in this transformational change. Because the Bevan Commission is speaking to the people and to politicians and to public and to the healthcare professionals and other constituencies as well, and talking about this transformation. And you're absolutely right. If we're looking at transformation, we're not looking at tinkering, we're looking at changing the whole way the thing works. And you can't dismiss population health. We've got to be looking at that in particular. So I totally agree. It's a huge task, but unless we pick up the baton and run with it, it'll never be sorted out. So.
Mansel, I'm not sure whether when I heard you talk about lack of engagement, I think I heard you talking about that as a patient focus. If that is so, then I think that there's a piece.
The lack of engagement and urgency, I think that is. Is that the one? Is that what you?
Yes.
Yeah.
I might not have. My sense when I listened to that list was there was a piece that I thought was missing.
Yes.
In relation to. It's kind of might be summarised as organisational design, organisational development. It's the form by which we achieve some of that. I think that, in summary form, I think that what the challenge for all organisations, and I think it's especially true for health organisations, is how to move from old command and control forms to building organisations that facilitate self-directed action towards collective goals, and I don't think that many organisations have cracked that.
No, they haven't. And you've just defined leadership. You've defined it. Concerted action towards common goals. That's what leadership is about, and that's why I think Jonathan wants there to be a particular emphasis on what is meant by leadership. You're absolutely right, and I suppose when you read my paper, you'll see that isn't implicit, it's explicit. You can't just do the same things with the same structures. You can't, in fact, but just structural change is of no use. We've seen that unless you've got cultural change, and you've got to have that change in belief that that's the new way that the thing should work before you get there. And there's a huge emphasis on that. Yes, it isn't articulated in the list I read, but there were several other things I didn't put in because of time. But you picked up a critically important one. Yeah.
And can I just add there?
Yeah, please.
Because we've had lots of discussions around moving this beyond just healthcare, moving it beyond hospital, tertiary care, and really looking at primary, secondary services, but broader community services, human services, housing,
Transport.
Transport.
Education.
I mean, the things that really make a difference. And it's all, I guess my thinking is it's more around collaboration across those than it is about just the healthcare system, if you will.
We've got a phrase for that, which you must have heard. Health in all agendas. Health in all policy agendas. Now, it would be wrong of me, you know, as I say, as a guest in this country, to go and talk to people in Wellington, although I have, and said, you know, I don't particularly agree with the way forward, but I'm doing it very genteelly and saying, you know, I understand the situation and I'm only a visitor. But actually, let's be honest, you've got to look at those other issues if you are going to change the health of the people. If you're going to have a step change in the improvement of the people in New Zealand, all communities, let's not beat about the bush, all of them, then you've got to do it. And, you know, we talk about a phrase called proportional universalism. Sounds awful, doesn't it? But what it means is that when you're looking at health improvement, you want all the people to benefit from any interventions in public health or community health or profession or population health, but you want to focus more on those areas where the disadvantage and the health inequities are more common and more severe. And you're right, Pam is right, you know, we've got to look at all those things. They are important, but we want to make sure that people realise that we're not focusing solely on that, because there are other key challenges to the healthcare system which need to be addressed at the same time.
Can I go back to Alex's point? I think there's something that we need to say. I think in the Counties Wildlife Forum, I think there's a great concentration on top-down management equals leadership. We have no forum or very little forums where leaders can spring from whatever part of the organisation that may be. And I think that is something that we need to say, and I think we need to encourage to actually look at how we collaborate at all levels.
Yeah.
It is about working as peers to peers, but it's about also starting to get those leadership roles recognised, whatever you are. I can't join a leadership course or learn certain skills because I'm not a manager.
Do you mind if I ask you what you do?
Okay, I'm a pharmacist. I run pharmacy services. I have a layer of management between me and my service manager. And then there are lots of layers up. I saw your meeting today and wanted to come along, so I thought it was important to...
No, I, without being critical of the organisation of whatever was top down, up down, I'm not going to do that at the moment. But you're right. I mean, let's be honest. We've got to be
strengths, and it's about engaging the strengths of the individuals.
Absolutely.
And making them motivated to
Yes.
be engaged by identifying what those strengths are, what those weaknesses are, but actually using our people's strengths. We say we have the tools, but we're not using our
That's
people.
right. That's right. And
Sorry.
no, and you, when asked to be transparent, when you're asked to come in as a visiting chair, you don't come away and say everything in the garden is lovely. You don't. I mean, what my report will say, you know, the intention is there, very much so. The tools are there, but people need to be engaged. Now, one of the big areas that I've been talking to with Jonathan, and Jonathan is talking about with Stephen, who's also visiting from the UK at the moment, is leadership. That's very, very important, what you've said there. I found that there isn't that engagement with leadership when I talk to people. They don't talk about it in, not just in leadership terms, but I mean in language that means we want more leadership. But what you've said is exactly what we have to exploit. And I think that Jonathan is looking forward to setting up a leadership academy. I mean, that's a working title now. Some of our further seminars here will be about that. And certainly, if we are fortunate enough to put together a sort of independent commentator, as we have done in Wales, they will be endorsing leadership as number one of the reasons, of the ways in which you get transformation. You don't get it otherwise. So I endorse what you said there.
This is purely my own opinion, speaking from my point of view as a frontline now in Africa.
Yeah.
I really believe that DHB has to be really much more staunch police message about self-imposed risk, lifestyle behaviours. I think that they've been PC for far too long, and then you just spell it out in no uncertain terms. And economic and politics of healthcare in New Zealand today. I just have I try to inspire and motivate people, and I dwell a lot on the message of you can change it yourself.
Yes.
You don't have to wait for a DHB or any other person.
Absolutely right. But you've got to have the culture to be within which to do that.
I have a supportive network to have that backing there, and I'm afraid where I come from, Marikana, it's not there.
What do you mean by...
Whether you call that poor leadership, lack of leadership...
No, I mean...
I think we all have to share the message that we're in... I think the country's pretty much almost bankrupt, to be honest. Another earthquake would do it, and we have to be very strident that if you say people need to change their lifestyle behaviours, then you really need to preach that message, have it on all the walls, and everyone be at one in the...
So when you say you're being people are being too PC, you mean they're not really saying the truth? They're not saying things that people...
They're not saying it the way it's going to have an effect. They might be saying it, but it's not in terms of, well, we feel sorry for you because we know you've come from a full background of colonisation and so on. Maori themselves have to get out of that psyche because that's what's holding them back.
Yeah.
They've been victims for long enough.
That's right. And it's
I tried to talk to Maori, and mostly young Maori, I think, you have some sort of traction with that message. Maybe not people over my age.
Yeah,
but
no.
I just find that young people, you have to try and inspire them to get up to be self-determined and be more responsible for their health. Otherwise, it's not going to happen.
Yeah, I went to a Maori faculty meeting of the Royal College of General Practitioners a fortnight ago, and I picked up this disparity in views amongst Maori doctors. One lot is saying, oh, there's a huge cultural, historical colonisation legacy here which we've got to address, as well as addressing the health inequities. And if we don't address it, we won't address the health inequities and social disadvantage. Whereas the other group, equal, they're friendly to each other but equal, saying, no, let's get away from the colonisation, victimisation thing. Let's address health inequalities and social disadvantage amongst Maori, Pacific Islanders, people from Wales who settle here in exactly the same way. But you were saying that there needs to be clearer messages sent out.
Far stronger message. If you believe in the message, you should be proud to say it.
Yeah.
I believe it, that's why I say it.
Well, of course, yeah.
Can I give another context
Yes, sir.
to that? In that, within the community, the apathy towards their own health can be generated too from the DHB in regards to, we will do this for you, we will give you this, we will supply you with these resources. We're seeing a groundswell within the community to be able to support their own solutions, to look at what they can do themselves rather than rely on a DHB or a Ministry of Health to provide those sorts of things. And I think that the engagement issue is about not allowing that genuine experience, even though it might not be a clinical or medical experience, but genuine experience about what they can do in their own homes, in their own communities, to see the solution being arrived at in a different way. And so I think that one of the things we really do need to look at is that engagement component, but be genuine and realistic about what sorts of information can be translated. Some of the apathy within our community as well is about the sustainability of these things.
Yes.
We have a number of projects that we get up and running over a period of time, and then it's not that that communities they need the time to be able to embed that sort of thing, to be able to develop the solutions and be able to deliver on those solutions over a period of time, not this sort of 3-year cycle or 1-year cycle type thing. Actually, this is about generations, and it's not about just a 1-year and 3-year cycle.
And I think there are areas within what you've talked about now. I mean, I've heard the word whana for families, and what I've seen of the different initiatives, they seem to be ideal. But one that strikes me as very important, and I was talking to Peter Gluckman, the chief scientist, about this, because he shares it, and that is both in Maori, Pacific Islander, and I can't remember the name for Paka. Is it Paka? Pakeha communities. We need to focus anyway on those reproductive and early years, because that's where we're going to see the greatest changes in the family, is in, focusing both clinically and in a population health on those early years. And I think I picked up some of that when I was talking to the people in the FANA networks.
Terminology has a big part to play too.
Okay.
And I was happy to hear your thoughts on clinical leadership, not just being within the clinical
That's right. Yeah.
role,
Yeah.
but actually much broader than
Yeah.
that. Because when people talk about clinical leadership, the patient sort of turns off a bit. They
Agree.
look away from that because they think, well, it's actually a doctor and a nurse's role,
Right.
or allied health role,
Right.
as opposed to actually it should be their role too.
I agree. I don't like the word. I don't like the phrase at all, and we've got to sort of think
Well,
of
we're
better
using
ways to
that.
do it. Yeah,
In all of our
Yeah.
literature, in all of our brochures about clinical partnerships,
I know. Yeah.
but actually it's about clinical and community.
Yeah, the word clinical means bed, doesn't it? That's what clinics means, bed in Greek, and we've taken it a long way from there to mean objective in some areas and doctory in another, and we've got to change. And words are important, I think, in transformational change. The way in which words are perceived are extremely important, so we've got to focus on that. I know we've only got till 12
o'clock, 'cause there's a meeting at
because of the meeting, but we'll try and... Can I move and ask a few pre-prepared questions? Now, I said this before we had this discussion, some of it is relevant here. We are all working in the field of health, right? What do you think, could people give some ideas about, are the most important objectives for our work? Is it self-evident, or let's just talk about it a bit. What do we think of as working in the health area of health? What are the important objectives as far as we are concerned? That's what makes us do our job. Can somebody talk about that?
Meeting and exceeding the expectations of our patients.
Right. Okay, that's a very good definition. And that's the definition of what used to be total quality management, meeting the needs of those you serve. Of course, the point is, needs are fine, its expectations are difficult because they could be wants and you can't meet them.
Well, but actually done work is moved from needs to wants.
Oh, yeah,
Most, if you ask patients, they are not asking for you. Their wants are probably quite reasonable. It's about actually asking not what is the matter with them, but what matters to them.
Absolutely, and you've used the word reasonable. I agree with that. That's a good definition. But you've stymied the debate now because you've given the right answer. But what else? No, there are other things that we want as objectives as well.
I think because you've got, you're talking about us on a day-to-day basis and meeting those objectives, you've got to somehow make really clear to the individual who's working how they fit with that. I totally agree with Mary, that is the ultimate thing that we are aspiring to do in our work. But the disconnect between what I'm doing in terms of down in the basement filling the tablets for the patient, it's not maybe as fundamentally obvious to everybody.
All right, then this is another... I'm putting this...
How you engage the workforce to recognise exactly that.
Right. Another question I prepared previously and is relevant to that, and I'm going to give it you now, is in order, still thinking of the objectives things, but in order for you to be more satisfied in the job you are doing, what has to change? And anybody else? No, what has to change?
Getting feedback in relation to my performance against meeting patients' needs and expectations. It's kind of closing a loop, so I know that what I'm doing is...
Now, don't you get any?
I don't think... No.
You don't know? Well, the fact you don't know isn't good.
You're doing a
right?
great job, Alex.
I don't think you do that.
I just don't think you should, but certainly don't ask. But yes, no, feedback. We do know that feedback is extremely important, both negative, if it's done sensitively, and positive. And if there is, we take this down as we can't go into big discussions at the moment, but it'll be taken into account. Measurement is very important. Jonathan has put in my brief knowledge management, right? And that's part of the paper that we haven't mentioned. It'll be in the paper. Because unless you not manage your knowledge well and show what's happening transparently, there was a book written by somebody, it was called The Visible Hand, right? I can't remember who it was. It was a guy who talked about pawns, and he's a famous, well, anyway, he's a philosopher, come health guru, and he writes about various things. And one thing that really got me was the visible hand and the invisible hand. What he was talking about was, even in communities where you don't have that much competition, and in Wales we're not going to have a competitive NHS, what really drives forward quality and improvement is the publication of data, transparent, well-held data. And it also is a very able feedback to people to know that, well, it's worth doing what I'm doing then. You know, we are closing this gap, or we are doing things faster.
I think more viscerally than data, and not very strong on measurement, is patient stories.
Oh, yes.
And we've been doing that for a while.
Good.
We find that engages people.
Yeah.
The other thing I'd say is, all of us should, even if we're in the basement, we should have some patient contact.
Yeah.
Even if it's just with a focus group,
Yeah.
or with a
Okay.
patient
We do
and
that.
family advisor group talking
Right.
about their experiences. I
Do
think
that.
that brings
Before
it
you
back
go.
towards.
Okay, we'll do that before I go.
It's got to be in a person's context. that
Oh
you
yeah,
really
but we
get
could
back
do
to.
that, and there are lots of things like the Esther project in Scandinavia, in Linkoping or Jonkoping or whatever. I mean, that talks about, you know, patient stories, how important they are, and we could do something about that too. Could I ask that lady who she is? No, you. Yes. Yeah. Sorry.
Mary said a clinical director of the prison.
Oh, I've heard of her. I've seen your name on a bit of paper. Nice to meet you. So this gentleman here. Oh, good. That's what I am too.
I'd like to talk about living the values, because
Yeah.
I think that that's important. I think sometimes we get very complex about plans and strategies and things. And we don't do the simple things like saying, how can I help you? And you're doing a good job. And coming back to the engagement, it has to be a two-way thing. And linking that to living the values, I think it's wonderful that you've come and said, I've got a paper to the board and I want your input.
Yeah.
That's refreshing to me, and I'd be very pleased along with the others here, I think, to be able to look at that and say, well, look, you've got that a little bit wrong, and you're going to lose credibility, and so is your paper unless you engage. I think we've got more than enough leadership groups. I think the academy, I like the idea in part, but we've got lots of academies of people who are experts. What is happening is that we're not being introduced and using this as a co-design, but rather than recipients of tablets of stone.
So you're co-production, co-design,
Yeah.
yeah? Well, although, as you will gather, I cannot present the paper to you or anything until I've presented to the board. I mean, that's just courtesy from my part. I shall make it quite clear that it is very, very important to gain your views about the paper, and that we've talked about certain things which have influenced the paper already, and I'm sure Jonathan would expect me to do that. I feel very strongly about that. Transparency, openness, frankness is so very important. Trust is so important. If you start trusting people and you think that they are working for you to your own ends, same ends as you, then I think that makes a huge difference. You can't trust people. You can't have trust if you're not transparent. So I commit myself to that, and you know, move the board along in that way if I possibly can. And I'm sure I will be able to do it in some way or other. So a lady there, and then there's a gentleman below. Right.
And I just wanted to build on the concept of engagement with our patients and communities. That way around feedback. It's important that who's giving the feedback, you know, it makes more value if it's moving away from patients and communities being passive recipients of healthcare. Then how do we actually partner and
Yes.
you know, have a full of all contributors?
Yeah, and of course we're all talking really about autonomy and self-esteem as well, you know, in self-management, whatever you want to use it. And we've been looking at health literacy in Wales, you know, and finding how poor it is. And that one thing we haven't talked about, and we haven't had time to go into it in detail, but is if only 30% of the population have a reading age of 8, as they do in Wales, right? How can you expect to get some messages across anyway? it's not just writing, is it, health literacy? It's about understanding. And when you talk about engaging with the patients, we've got to be aware of that. And make sure that whatever we're communicating is understood, and that we, because healthcare professionals can also suffer from health illiteracy as well, you know, in not understanding there. But I think self-management and self-care is really important there.
Adding on to engagement, I think also communicating the vision to the frontline staff and how me sitting in the patient's room.
How does it affect you? Yeah.
How does that link to the vision of the DHB? And that will take us forward. It's not enough that I have an overarching vision, but it has to be, every single staff member has to identify to that vision and see how they contribute to establishing that vision and values. If that doesn't happen, that's where the engagement is lost, and the vision keeps sitting up there without being translated into how we deliver.
Yeah, agree, absolutely. Yeah.
But I think sometimes we spend far too long on a paper exercise of what the visions are.
Yeah.
I think sometimes it would be better to demonstrate them, get runs on the board with something that shows a particular part of the vision, and then share those stories. The last 2 years we've talked about our visions and redefining them and our mission and all what's happening, and it hasn't actually moved us forward. And I wonder whether, just like quality improvement, sometimes doing something that works and then...
Totally. I mean, you can't improve upon. I know it's easy to say that, I know, but it's absolutely right. And I'm well known for saying to every problem, look, pick up the baton and run with it until somebody tells you to stop. Keep using it. That'll be on my grave, I think, and they'll say, he's run with the baton far enough. Full stop. But that's right. You've got to have practical examples and get on with it. And I've only got 3 months, so I've got to get on with it. And that's why I'm sort of pushing as much as I can anyway at the moment. There was a gentleman at the back.
Yeah, just around your point on knowledge management, it kind of picks on what you said, Mary. It's all good that we look at having the ideas of having systems in place for capturing data in our knowledge management space. But what we need to do is make sure we've got processes and actions that make that data useful so we can make better decisions.
Yeah.
You know?
Usually, I mean, one could talk about the concept of an observatory, you know. Yeah. I mean, we've got an observatory. It's taken a long time to put together. And it's still not wonderful in Wales, but it's there. And what it does is I'm chair of Public Health Wales, and we find out what the people in public health need, and we talk to our observatory and say, we want you to look at X, Y, and Z, but we don't want you just to look at the data. We want to tell us what it means. And then arrange groups. We've got an overarching group now of our research development and observatory and service improvement. And, you know, we talk together about what the data is, what it may mean, and can you get further data to mine further data to prove or disprove that. And that informs decision making. I think that's...
I mean, even this is a knowledge management activity in itself. And it's, you know, it's what are we going to do, you know, stuff like this.
Yeah,
these
well, I think
and setting sort of processes up so we can take it further.
Yeah, well, if knowledge management stuff that I've seen Jonathan talking about and talking to me about, that's a critically important part of the whole thing. Otherwise, what's the point in just capturing knowledge? It means nothing.
Well, and can I say something along that line too? Is when you have the data, then it belongs to the community, and it should go back out into the community so that they can look at what are the greatest needs in our area, and then can do sort of the ideas that you were talking around. You know, how are we going to deal with this issue? For our community, the data tells us this is where we need to concentrate. Let's do something locally.
There's a lady up there.
Whether the reason that we are not properly engaged with the communities we serve, is it because we are not sort of keeping to, there's a vision statement that's made. It's not broken down to the finer details. Simple things like housing and
it's important.
Safe food and, you know.
Yeah.
Where is the obstacle that we don't reach our goals?
That's right, and in fact, we won't have time because it's nearly 12, but the thing that I mentioned here, you know, can these I was asking about objectives. Can these objectives be achieved? No. At the moment, I mean, they're not being achieved at the moment, but yes. And what's stopping us from achieving them? I know it's a big question, but that's what you're saying. And one of the things you're saying is we've got a vision, but the vision doesn't mean anything to the person in the clinic or whatever. It doesn't mean anything to you in what you're doing. You can't see how you link up, and somebody else said you did. How can we get feedback to say that what we're doing is actually achieving that vision? Yeah? I mean, that's what we're talking about. So there's a need to have some clarification of all that. Yeah?
So we're talking about health integration.
Yeah.
One of the key objectives we should be looking at, and it's a real difficult one, but we can't not do it, is the integration of the social aspects of what we're doing, because housing will impact on the health of our people. Poverty will impact on the health of our people. So in regards to we're doing all this work within the health sector, we can't achieve those huge goals around the transformational goals that we're looking at unless we engage with those others and actually do some practical, and there are some practical hubs that are working at the moment. Do that to make sure that the whole system is looked at.
And even if it's not integration, at least collaboration.
Yeah.
At least
I mean,
something.
I don't know that's enough. That's not enough. The collaboration has been going on for years, and everybody's sort of taken their silos and working in that. Yeah. But actually it's not working in regards to the people that we're supposed to be.
If it's not working, something must be done.
Yeah.
In fact, it is coming to the end. You, sir, I don't know who you are, if you could tell me who you are.
Manu Sion.
And what are you?
GMO Pacific.
All right. You've said what I wanted us to say today, right? We can't do this alone. We have to make sure the healthcare is better, quicker, delivered, whatever. We have to do that. But actually, it's only perhaps 30% of the problem. The problem has still got to be population health and addressing the things you said. To defend collaboration, though, what we've done, we're probably a bit ahead of you in the population side of things in Wales. And what we find by going out and talking to people in the street and focus groups and whatever, is that their definition of integration, people's, was, I don't really care who's delivering it to me, as long as I get the service. There's so much argument about it should be the social services, it should be community health, it should be schools, right? And what the people in the street are saying is, look, I don't care who the hell does it, really. I want to have a seamless service. I want to have, be able to go right through this, and I don't care who delivers it, whether it's local authority or whatever. Now, that's integration to them, but that's probably integration for you as well, isn't it? Yeah.
Can I just say that Maori do care who's delivering it? Oh, yes, they do. That's why we're here. So, I mean...
No, well, can you expand upon that? Because I don't understand what you mean, they don't care who's delivering it.
No,
what do you mean by that? Do you mean...
Well, my Maori for Maori is a government initiative that's been in for the last decade, so Maori do care who delivers it. I just thought I'd let you know that. I'm not sure. I can't speak for Pacific Island people.
Yeah, but you mean you don't? You mean? Sorry, I got to be an ignorant, ignorant
Maori,
monsieur.
like the services delivered, was very mindful of their cultural.
Oh yes, yes. I'm sorry.
I have to tell you, they find that Maori deliver that best.
Yeah. Well, I think people in Merthyr Tydfil in Wales would like it to be delivered by people from Merthyr Tydfil in Wales. I'm not denying that. What I'm saying is the actual service itself. Whether it's delivered by the local authority, whether it's delivered by... Well, that's what I meant. But I got it. No, I didn't mean somebody coming in and saying, hey, this is the way we do it now.
Can I just make a point to everybody? I've put Pam's email address up on the board there, so if you have ideas that you want to get through, head them towards Pam. And also, just a reminder, the co-ITF blog is busy and happening again, and we'd love to hear your voices. There's guest blogs. I'd like to know what you're reading and tell others why they should be reading those books as well, all that sort of thing. So Janet Haley is the person to send. So Manu, for example, maybe you could write us a blog.
Yeah, yeah.
Have we
On
got
today.
control of our website yet, or is this still coming from America?
No, this is co-ITF blog.
We always have control of our website, but like all websites, you use people to provide the IT framework for it, Mary. So, I mean, we've always had control of it, but we're doing something even more exciting, which is adding to it with the blog. So.
And there's a blog about me going with Eric over there to the marae and Tikanga, isn't it?
Can I just say that doing this individually is fine, you know, if you want to do that, that's fine. But actually we find it better in a group.
Yes,
And
of
so
course you do.
Pacific people, Māori people, they tend to talk more rather than write screens of reports and research. So I wouldn't sort of say that this is the only way, and we need to be able to go out to those communities and those people, as I say, whether it's patient-focused or community-focused, to be able to get their valuable experiences, those stories that Mary talks about. They're the bomb.
They are. And in fact, not to dwell too much upon this marae, which I really, really appreciated, was in the afternoon we had case studies, okay? Māori case studies about actual cases and how they were managed badly because Māori values and culture and principles were not applied, and then how they were managed overnight when some person, I remember very vividly, came in, and if they'd come in and presented to me in Wales, I'd have said, this person's schizophrenic, you know. And clearly, there was no need for that. The person was not schizophrenic. The person just has a different belief system to mine. And that meant a huge thing, I think, to me. From that. We're going to have another one. We can't have it next week because I'm speaking to the board. But we can the week after. Probably on the Wednesday. I can't remember now, but it'll be a Wednesday. We publicise it well.
Yeah. Thank you.
Thank you very much.
For doing this, and let's thank Mansel, and then let's look forward to the next one.
Thank you.